this week's Cardiology Countdown, we'll begin in San Francisco with an analysis of the SF Activate registry that looked at STEMI activation to see what percentage of patients were sent to the cath lab but were false positives, and that is not found to have a culprit lesion. Interestingly, over a 3-year period, they found out of about 450 or so activations, over a third were found to be false positives. And patients who had LVH or cocaine use, and interestingly a history of coronary disease, increased the likelihood of being a false positive. And so this is obviously extra work for the cardiology teams in San Francisco, but likely across the country, and will hopefully help refine the clinical characteristics that would activate the cath lab as opposed to doing other testing. At the number 2 spot is an interesting analysis in JAMA that looks at the risk of stroke of women versus men. And as has been seen with many other diseases, in atrial fibrillation, the risk of stroke was higher in women. Now, in part in this registry of nearly 40,000 patients in Quebec, the prevalence of other risk factors was higher, such as higher age and history of congestive heart failure in women. But even when correcting for that, there was about a 14 or 15% higher risk of stroke in women. And so another thing for us to be on the lookout in the high-risk population to try and optimize therapy for them. And these findings were despite use of warfarin. And so as we consider the newer agents, could we have gender as part of a strategy that we keep in the back of our minds as to who are the high-risk patients? And at the number 1 spot are new prevention guidelines from the ESC. There's a very nice document with lots of color-coded tables that walks through everything from risk assessment, where they use the SCORE assessment, but recommend use of that clinical-based thing. Other biomarkers have all the evidence laid out for their support. And then all the therapies for long-term treatment. They adopt the target of less than 70 milligrams per deciliter for LDL for patients with established coronary or vascular disease, and then less than 100 for those who have multiple risk factors and known cardiovascular risk. There are also recommendations where they give preference to the stronger P2Y12 inhibitors over clopidogrel, since they've been shown to have better outcomes, although obviously balance that with bleeding. And then they get into a lot of the mechanics of how to provide preventive care and to set up systems to involve nurse practitioners and other healthcare professionals to help in the education, to a call to action for cardiologists to be preventive cardiologists and really work hard at all this. Obviously involve lifestyle interventions, encourage cardiac rehab when appropriate, and encourage governments to get involved in trying to help on the prevention side. So a really terrific guideline. Encourage everyone to take a look at it. So for this week's Cardiology Countdown, I'm Chris Cannon.